So the stem is patient underwent right hemicolectomy and nurse noticed decrease urine output. So what can be the possibilities? You are given a chart, fluid chart is provided. So the chart, you need to see the chart. It has got input and output. These are the two things. So what you see among the input, it can be oral or it can be nasogastric, percutaneous, IV, hourly or running. So output will be, it be urine, bowel, vomit or aspiration, drains, total. So the urine intake and output chart. So generally it is urine intake and output. So low urine output means it is supposed to be something like acute kidney injury. So you will be asked to differentiate how will be AKI. It can be pre-renal, post. The three things. Pre-renal, post. So suppose this is the kidney and this is ureter. So pre means before. Anything which causes low supply of the blood to the kidneys, it can be dehydration or sepsis. So that is shock. Renal means it has to be pathology inside the kidneys, glomerulonephritis or any drugs damage the kidney. And post-renal, it has to be stone or in the bladder, prostate or something like that. So pathology, what is acute kidney injury? So what happens? Initially, there is polyuria. Polyuria. What is this polyuria? There is abundant urine. So it is because kidney cannot concentrate. Whatever the blood is coming and ability to concentrate urine is lost, so the patient is passing diluted urine. So that is the physiology of polyuric phase. Then why uremic patients are anemic? Most of the patients having uremia, they have got anemia also. So uremia, it can be because of, as we know, erythropoietin is erythropoietin is important to formation of the erythrocytes and all that. If there's deficiency, then kidney damage, deficiency. So most of the bone marrow toxins can also lead to these bone marrow fibrosis. And so now what will be the changes? What happens in acute kidney injury? So first of all, you have to remember whenever kidney injury is there, so the person is losing potassium and potassium is lost. Sodium is also lost. So what you need to see is sodium is lost and potassium is retained inside. Sodium is going out. So there can be hypo when the potassium is increased. Potassium is increased or potassium is decreased. So you have no T but long QRS and long PR. So this is hypoglycemia. No potassium, no T. And peak T's, peak T waves are the typical feature of hyperkalemia and prolonged QRS. Then functions of potassium. What potassium we do in the body? So it has got electrolyte balance, intracellular, extracellular. So conduction of nerve impulse, muscles contraction, it can be cardiac muscles also. So what happens of potassium on cardiac muscle? Potassium causes heart to be dilated, flaccid and decrease the heart rate and can block the conduction. So block the impulse. So increased potassium level make action potential less negative, decreasing and efficacy of cardiac muscle contractility. If potassium is increased, contractility is decreased. So how potassium homeostasis is made, potential homeostasis there. It is inside the blood. Now, so it goes inside the blood through GIT by intake, and second is endocrine aldosterone or insulin, as well as renal acid base balance. So what happens? Aldosterone promotes excretion, and insulin stimulates uptake, so it decreases. So when potassium is low, that leads to again weakness, muscles, arrhythmias, paralytic ileus, confusion. And increased potassium will also leads to arrhythmias, muscle weakness. Here is diarrhea and abdominal pain. So how, if the potassium is increased, the first thing is you do, it's an emergency B, C, D, E, and then you need cardiac monitoring, ECG. So it depends upon, so more than 6, that is severe hyperkalemia, you give calcium gluconate 10%, 10 ml in 10 minutes. You insulin, soda bicarb, salbutamol, calcium gluconate, and hemodialysis. If the patient is confused, dementia, how will you consent for dialysis? There is no, you cannot consent. What are the indications of dialysis? Uremic encephalopathy, acidosis, hyperkalemia more than 6, pulmonary edema. So the next, you are called at night. Patient is 45-year-old, underwent laparotomy 9 hours ago for diverticulitis. Now complaining of abdominal pain and conscious, 148/95 BP, heart rate is 120. Surgical site is normal. Medication charts you see, no paracetamol dose at 18 hours. It has to be given. So now patient, that's why patient is getting pain. What is pain? Define unpleasant sensory and emotional experience associated with pain. How to assess? It can be description by verbal, numerical scale, verbal assessment, analog scale, VAS, faces for the child, that is called as Wong-Becker functional assessment. So what is visual analog scale? It can be scale, pain as bad as could possible. So we have to visual analog scale, moderate. Considering visual analog score and patient describe, say what instructions will you give? That has to be managed by WHO pain ladder. So how is this pain ladder? First is paracetamol 1 gram IV. Then if not relieved, you have to go for second step is morphine. It can be IV, IM, subcutaneous. Dose is around 10 milligram, 4 hours. And here if it is not relieved, consult pain or anesthetist. If pain fails to settle, what you are going to do? Ensure pain is relief medications, contact anesthesia. Now, post-op pain, what are harmful effects? So patient is in pain, so he will not take, that is called as diaphragmatic splinting and leads to hypoventilation, leads to atelectasis. Second, patient can be having increased heart rate, that is tachycardia, chest infection, anxiety because of pain, immobility, so stress is for increase. So what are side effects of morphine? So it is respiratory depression is number one, itching, nausea, vomiting, constipation, decrease consciousness level and euphoria. So type of pain nerve fibers. Nerve fibers. They have got A delta fast. Delta is fast. C are slow pain. So pain pathway transmitted nerve ending to the fibers to the dorsal horn. So this is the dorsal, this is the ventral part. So reflex is like this. From the dorsal, this is first order neuron. This is the Skinner sensation, it travels first order neuron. This is dorsal horn. This is ventral. So dorsal horn nucleus, from there it goes up, this second order neuron, up to second order neuron, also opposite side ascends to spinothalamic tract, spine to thalamus. So here is the thalamus. Then it crosses from thalamus to somatic sensory, post-central gyrus. Somatic sensory, this is third order neuron. Post-central gyrus. So substances which are released during pain, these are free radicals, serotonin, histamine, bradykinins, leukotrienes, substance A. Patient pain fails settle. Anesthetist to recommended patient control analgesia. What is PCA? Patient control analgesia. So what are the features specific? The syringes are locked container. So a patient cannot give more than that. 5 minutes prevent morphine of being administered to. The lock period is usually 5 minutes. Fixed bolus. 0.5 ml to 1 milligram. That is 0.5 ml only. So you have to just press the button. What are the problems? So it is limited. Problems are limited. Pump failure, eyesight failure, benefit satisfaction. Give example of opioids. Common opioids. These are non-synthetic, semi-synthetic and synthetic. Non-synthetic, morphine, codeine. Semi-synthetic, dimorphine, dihydrocodeine. Pethidine, fentanyl. Mechanism of paracetamol. Paracetamol, antipyretic as well as analgesic. COX-2 inhibitors, which inhibits synthesis of prostaglandin. So toxicity of paracetamol, you have to give charcoal, gastric lavage, charcoal, and acetylcysteine. Station stem is 45-year female on or having female, she is suffering from rheumatic arthritis, taking steroids. So patient has to undergo surgery. So This is nothing but a case and discussion theoretical question answers on steroids. So first question is about steroids. So if you are asked as to what are steroids, so maybe answer may be difficult. Just to remember that steroids are 4 cycloalkane, 4 cycloalkane rings. These are the compounds that contain arrangement of cycloalkane rings which are joined together. So just to remember cycloalkane. Then what are the layers of adrenal cortex? So just remember this is cortex and central medulla. It has got 3 layers. Outermost layer, then middle layer, then inner layer. To remember this, outer is G, middle is F, innermost is R, GFR. Glomerulosa, fasciculata, reticulosa. So this secretes mineralocorticoids. Fasciculata secretes cortisol, glucocorticoids, and this secretes sex hormones. Mineralocorticoids is aldosterone. This is cortisol, and these are the sex hormones, FSH, these follicular hormones. Then aldosterone, when it can be increase or decrease. Increase in Conn's syndrome, decrease in Addison's disease. So, what are the actions of aldosterone and cortisol? So, just to remember, aldosterone, what does it cause? This is mineralocorticoids, mineralo. So, minerals basically sodium, potassium. These are the basic things. So, increase in aldosterone or something, what cons means increase. So, it causes sodium inside, potassium outside. So reabsorption of the sodium. So aldosterone causes sodium inside, potassium out. So it also helps water and sodium balance. So that causes water inside. So another thing, because of this, acid base balances. So excretion of potassium, this helps. The second hormone is cortisol. It's very important hormone, fight and flight. So cortisol, it helps most of the time is most uh, glucocorticoids, and it causes it's anti-insulin. So it is a fight hormone, insulin. So causes increased blood glucose level. Then it stimulates. So for increasing blood glucose level, gluconeogenesis, formation of the new from the other things. So it causes protein synthesis in liver. It again stimulates breakdown of fats, lipolysis, and it has got cortisol. It can be used hydrocortisone, all that anti-inflammatory effect. It also suppress. Anti-inflammatory means anti-immunity effect, immune suppression. So it is a stress hormone. Anti-inflammatory, immunity, glucose and protein lysis, insulin, increases blood glucose. So these are the functions of cortisol. So whenever there is a surgery involved, patient is on steroids. whom you will involve. So these have got a role of endocrinologist because hormones are there. Then anesthetist is also there and surgeon. So consultant is multidisciplinary. So how is pituitary, hypothalamus, pituitary, adrenal hormones? So topmost is hypo in the brain. Then from here pituitary. So it has got anterior and posterior anterior pituitary. From there it acts on the adrenal, medulla and cortex. So this secretes gonadotropin, corticotropin releasing hormone CRH that stimulates from here. The important is adrenocorticotropic hormone. This is important. Secreted ACTH from the anterior pituitary horn. So pituitary glands stimulate the gland to ACTH. Then adrenal cortex, because of effect on ACTH, it secretes glucocorticoid, mineralocorticoid, and sex hormones. Though these are the, then it has got a negative feedback. So whenever these hormones are glucocorticoid is high, it causes negative. This causes negative. So adrenal test. So pituitary hypothyroid. So any problem primary inside the pituitary adenoma or something will lead to direct increase in glucocorticoid. Any adenoma or something in the pituitary gland will lead to secondary stimulates more ACTH causes more. So in pituitary hypoplasia, if there is hypo, anything in decrease, so ACTH will be decreased and stimulation will be less and there will be ACTH will be less. In adrenal insufficiency, if anything, these hormones are less, so negative feedback will be hampered and ACTH will increase. So adrenal insufficiency, here cortisol is affected. In pituitary hypoplasia, ACTH is affected. So patient who are on steroids, suppose the patient is taking steroids, so and has to undergo surgery. The important thing is that most of the time the you have to think of adrenocortical insufficiency. So or it can be called as Addison's disease. So insufficiency, it is a stress hormone. So you need to have sufficient. So preventively 100 milligram of hydrocortisone is given while doing surgery before induction, and then for over 24 hours it should continue because stress is always there and stress causes decrease. So it, and post-operatively, post-op, it should be continued around 200 milligram IV for till patient eats and drinks normally. If he undergoes major surgery, it should be continued at least for a week. If the surgery is intermediate, just a dose up to 48 hours. If the patient is getting less than 10 milligram prednisolone, so that is it doesn't require any cover of the steroids. If it is more than 10, you have to give hydrocortisone on that. So how do you educate patient taking steroids? So they should not stop it suddenly. No stopping sudden. So tapering is important. One thing. Second thing is that doctors should be made aware that he is on steroids. So it is anti-inflammatory. So inflammation or it is immunosuppressive inflammation, infection can cause delayed healing of wound. So steroids may lead to osteoporosis. So there can be bone resorption, may lead to increase in weight, increase blood glucose level, muscle weakness, mood changes, peptic ulcer disease. So complications of, again, the complications are same. Wound healing will be delayed. Infections, bacterial, viral, Epstein-Barr virus, cytomegalovirus, cardiovascular system may cause fluid retention or hypertension. Endocrine may lead to diabetes mellitus, and muscle, it causes osteoporosis, muscle weakness. So cushingoid features. So moon face, puffiness and all that can be seen. Hirsutism can be seen, and stria. What are the considerations? So important thing is Addison's crisis. So what you have to think about this, uh, this sudden deficiency or delayed wound healing, wound infection. Anesthesia, what has to anesthetist look after this patient on steroid? Chest infections, electrolyte disturbances, diabetes mellitus, hypertension, BP can increase, and delayed recovery. Patient may have delayed recovery. What do you think about Addison's crisis? So Addison's crisis, what is there? This acute reduction of steroids. So it can happen because primary or secondary. Primary or secondary. Primary is, so what happens? The demand is demand and supply. Supply is decreased, demand is increased. So that is a primary fault. Secondary, it can be because of trauma, it can be any surgery, it can be infection and stopping exogenous, which this patient was already getting. So this was about, this is the station, the stem reads like this. What you know is that 45-year-old having acute pancreatitis. Patient is having pancreatitis 2 weeks ago. So now presents with vomitings, shortness of breath, not improving with proton pump inhibitors, increased heart rate, increased respiratory rate. So these are the findings. So pancreas. Now we have to understand about pancreas and inflammation of the pancreatic gland. What are the enzymes commonly? Amylase, lipase, everyone knows about amylase, serum amylase, lipase. So question is, already you have done this, LDH, lactate dehydrogenase. So lactate dehydrogenase, this is the important enzyme which need to test. Amylase, lipase, is it important, valuable, can it be done? So lipase levels are more specific to pancreas, while amylase is not specific. Amylase is non-specific. It can be increased to early, so because it has very short half-life, so it can be. So causes of post cholecystectomy. Next question is post cholecystectomy pancreatitis. So you have removed the gallbladder and the patient develops pancreatitis. So it can be any of the iatrogenic injury to the pancreatic or infections transferring from here, retained stones, there can be strictures. These are the post cholecystectomy pancreatitis. Patient comes with jaundice and ascending colitis. So now what happens? The another question is jaundice, ascending cholangitis. So this can be stones or stricture. 5 weeks after initial attack, patient presented with epigastric fullness. So patient presented with epigastric fullness. And what other things? Presented vomitings and dyspepsia. So this is 5 weeks after. Fullness, this is important. So fullness, it can be because of formation of pseudo pancreatic cyst. So what is this? This is the collection of, what does it gets collected? Amylase rich fluid. Amylase rich fluid in the cavity wall is false, so that is fibrous, or it can be granulation tissue, not a true wall. So what is difference between cancer and pseudo pancreatic cyst? What is the difference? So if you see, there are different things: fluid, then tumor markers, amylase level, and CT. So what you find in the cancers and what you find the difference is, how is the fluid? Fluid viscosity. Viscosity is increased, this is low. Then tumor marker 19.9 is increased, this is low. Amylase is high. Amylase is actually high in trauma, and this is low, pseudopancreatic cyst. What is the difference between true cyst and pseudocyst? So true cyst, the wall lining has epithelial cells, while pseudocyst has got granulation tissue. So in case of pancreatic necrosis, so what happens? What is investigation you are doing? So patient has got pancreatic necrosis, you do CT abdomen and IV contrast. What you see in CT, what are the things which you are going to see in CT? The fat stranding, CT findings, edema, collection of the fluid, pseudocyst, whether it is present or absent, abscess or necrosis. So what you get in biochemistry, biochemical Glucose increase, calcium will be decrease, magnesium will be decrease, albumin will be decrease. So it is opposite because insulin is not secreted, that's why glucose is increased. So why the calcium level is low? Why there is hypocalcemia? So what happens? There is auto digestion of fat. So that lead to free fatty acids, and that combines with calcium to get chelation. This is called a calcium get chelated, and that's why calcium goes down. Then later stages sepsis or decrease albumin, then hypoparathyroidism is there. Why there is hyperglycemia? Blood glucose is increasing because of damage to islets, which secretes insulin. Obstructive jaundice according to the cause. So now a question comes as obstructive jaundice. So it can be inside lumen, translumen, extralumen. Inside lumen, translumen, extralumen. Inside lumen can be stones. Translumen means in the wall, cholangiocarcinoma. Outside is CA, head of pancreas. So how do you manage a patient of acute pancreatitis? This is important. How is the management of acute pancreatitis? So this is a critical patient. You need so many things. So CCRISP CRIPS protocol, A, B, C, D, E approach. So admit patient in HDU, ICU, then give analgesics, IV fluids, oxygen, monitor, CVP, urine output, blood gases, liver function, urea electrolytes, clotting profile, calcium, glucose. These are the things to be monitored. Patient should get nasogastric drainage, antibiotics. If it is cholangitis, sepsis, necrosis, abscess, or you are going to do ERCP pre-investigation. Other things what you give is decrease secretion. So for that you give octatroid. It's very important drug. You give proton pump inhibitors to prevent stress ulcers. Then investigations, you do CT abdomen to understand about organ, any sepsis. Do ERCP if there is obstruction, gallstone, pancreatitis, or cholangitis. Supportive therapy for organ failure. Each organ is important. Cardiac, inotropes, lungs, ventilation, for blood, kidneys, dialysis, and nutrition, nasojejunostomy, feeding. So this is a critical patient. So what is the criteria? There are different criteria to know about the outcome. For that you do scoring. So that is called as Glasgow score. So in this, what you see is as per PANCREAS, pancreas. So P is PaO2, oxygen level. A is age more than 55, oxygen is less than 8. Neutrophil count is more than 15,000. And C is for calcium. If it is less than 2, renal urea is more than 16. Enzymes, what you see in the enzymes, LDH is more than 600. Then albumin, if it is less than 32. Then sugar more than 10. So what is this? P is PaO2, age is more than 55, neutrophil count, C is calcium, R is renal, E is enzyme, A is albumin, sugar. Pancreas, PANCREAS. So oxygen, PaO2, age, neutrophil count, calcium level, renal, enzymes, LDH, albumin, sugars. So this is the criteria called as Glasgow. And another important criteria is Ranson's. So Ranson's criteria, it involves mortality. It expects it decides the mortality. So what you do at the time of admission, you take out some, and afterwards. So here are a few things: age, WBC, glucose, LDH, AST. So age, if it is more than 55, WBC more than 1600, glucose more than 11, and LDH 350. So at the time of admission, based on initial and 48 hours. So if it drops, hematocrit drops to 10%, fluid sequestration more than 6 liters, calcium, if it goes below 2, PO2, if it falls more than less than 60, blood urea nitrogen more than 1.9, and base deficit more than 4. So the points are given 0, 2, 4, 6, 11. So 1, 2, 3, 4 different states. Here it is 1%, here it is 16%, here it goes to 40%. If it is up to this, it is 100% mortality. What are early and delayed complications? What happens? It can be of pancreatitis. Pancreatitis complications, early and delayed. So what happened in early? This can lead to necrosis, ARDS, acute respiratory distress syndrome, pleural effusion, electrolytes increase, glucose, decrease calcium, magnesium, albumin. Or late, it can lead to pseudocyst or splenic vein thrombosis. So if there is splenic vein thrombosis, multidisciplinary treatment, you need surgeons, hepatologists, hematologists, and then it has to be managed accordingly. So for radiological, now what happens? There can be hemorrhagic or radiological complications of coiling. You can do coiling. So coiling is a process where the veins, when they dilated, you do clear injury to any surrounding structure. Antibiotic in patient with acute pancreatitis. Quinolones has to be used. So how do you manage the pain? Pancreatitis has got very severe pain. So pain management in pancreatitis, as per WHO ladder. So here it's actually paracetamol has got lifting effect. So you need to give morphine, but theoretically morphine is avoided, that causes spasm. So paracetamol has to be avoided. Pethidine and morphine, patient control anesthesia. What happens? CRP. CRP is raised. It is non-specific acute which secreted from the liver. Any response to? Why there is tachypnea? Increased respiratory rate in case of pancreatitis. So patient has got, it can be because of ARDS, respiratory complication, or there is sympathetic overstimulation. So pseudocyst can be compressing it. What are the different enzymes? Exocrines and pancreatic enzymes. Now we see pancreatic enzymes. So amylase, lipase, protease. Other enzymes that present in pancreatic juice are neutralizes bicarbonate water electrolytes. So cholecystokinin, acetylcholine, vagus nerve, and secretin. So these are the different. What is pancreatic secretion stimulated? So how is it stimulated? So acid containing acid load in the duodenum. In duodenum. So this causes stimulating pancreatic secretion. Pancreatic is alkaline, so that acid in that cause.
So now the stem I get is 43-year female, epigastric pain, nausea, vomiting, diarrhea, increase bilirubin, ALT, ALP, GGT, and urobilinogen in urine. So this is the picture. So type of jaundice, so increased bilirubin in urine means it is obstructive or post-hepatic. What form does bilirubin circulate? So circulation happens of bilirubin. There are different forms. It can be free, conjugated with glucuronic acid, or it can bound to albumin. Bilirubin, how urobilin is formed and how does it circulates? So urobilinogen, how is urobilinogen? So this you have to understand about bilirubin, all that. So this is urobilinogen inside the urine. So once bilirubin is there in the intestine, from the liver it goes into the CBD, it goes into the duodenum, then into the small bowel. It gets deconjugated. Actually it is conjugation. So deconjugated in small bowel by gut flora. Some are excreted in feces and some are reabsorbed into. Some of reabsorbed urobilinogen is again excreted by the liver, but small amount enters. So it goes back circulation or into stools or urine. So this is the different. Why it is absent? Urobilinogen is absent because the obstruction to the flow of bile, bilirubin does not reach the gut. So it can be absent. So obstructive jaundice, what is there? It doesn't reach to the gut. So it's directly coming into the blood. So that's why it's not going into obstruction to the flow of bile and bilirubin does not reach the gut. What's physiological role of bile salts? So bile salts, so that causes fat digestion. It helps in fat digestion and absorption. How do they achieve this function? So this is by emulsification, formation of micelles. So how do bile cells help in emulsification? Bile cells have got anions. So bile salts have anions which is hydrophilic on one side. So this is one side and hydrophobic on the opposite side. So when the droplets, so they arrange in such a manner that all this is philic and this is phobic, phobic. All phobic sides are outside. So hydrophilic has a negative charge and the charge fat droplet and coated with the bile. So what is bilirubin conjugated? How is conjugation? So now this is about in small intestine, bilirubin plus glucuronic acid, conjugated bilirubin, glucuronic acid. So that is called as conjugated bilirubin. So it goes into small intestine, mostly reabsorbed in enterohepatic circulation. But when it goes into large intestine, which passes into large intestine, colonic bacteria, they deconjugate, they remove the conjugated bilirubin to urobilinogen. So 50% of the bacteria stercobilin and 50% reabsorb protein. Why blood clotting? So clotting is deranged because of fat soluble vitamin, fat soluble vitamin A, D, E, K. So vitamin K is important. So that causes deficiency in factor 2, 7, 9, 10. So this deficiency causes clotting disorder. How it is deranged? You measure prothrombin time and INR, PT. How to correct the clotting? You give injection vitamin K 10 milligram OD for 3 days. If you want rapid correction, then you need fresh frozen plasma or human prothrombin complex. How enterohepatic circulation maintains the blood salt pool in the heavily earlier defined enterohepatic circulation? Reabsorption bile cells from tribunal ileum back to the liver. Liver synthesis small amount every day. What could be the cause of silent obstructive jaundice? Carcinoma head of the pancreas, obstructive jaundice. Carcinoma head of the pancreas. What is the investigation? CBD stone, ERCP. If the patient has fever, chills, that will be called as ascending cholangitis, Charcot's trade. It involves fever, pain, jaundice. It has to be managed by CRISP protocol, high flow oxygen, IV fluids, intravenous antibiotics, urine output, antibiotics, cephalosporins. So the next station about the gallstones, a patient, young patient, right upper quadrant pain and epigastric fatty meals. So what can be the differential cholelithiasis, cholecystitis, perfect peptic ulcer, pancreatitis, acute pyelonephritis and all that. Most probable diagnosis is gallstones. So there are two different types, cholesterol and pigment. So cholesterol is because of high cholesterol content, it is fat, female, fertile, 40. So this is an oral contraceptive, and this is hemolytic anemia, sickle cell disease, biliary cystic fibrosis. So cholesterol stones, they are found by super saturation of bile, cholesterol, accelerated cholesterol nucleation. Pigment stone is also elevated levels of unconjugated bilirubin. Hemolytic. Young patient, no fever, investigation request is investigation over the LFT, ultrasound, CT abdomen, or MRCP. So, how will you treat the stones? Silent, assurance, painful, laparoscopic, percutaneous obstruction. How to clear bile duct? ERCP for CBD stones. MRCP, magnesium cholangiography exam detailed image. So, what are the indications of MRCP? CBD stones, if the patient has fever, what could be the diagnosis? Cholangitis. If the patient is not fit for surgery, you have to cholecystostomy, risk possible complication, bleeding and all that. What complication of the gallstone? Biliary colic, biliary obstruction, acute chronic cholecystitis because infected or antibiotics.
So the next stem is of 60-year male patient undergone a surgery for sigmoid colon. Post-operative day 3, he has tachycardia, heart rate as well as respiratory rate is increased, tachypnea plus fever. So the patient has fever. Pulse rate is 110. Partial pressure of oxygen is 90%. At room air, RR is 24. BP is 110 by 70. So this is the stem. Patient is having post-operative day 3. What can be the differential prognosis? So DD can be any one of the following, like pulmonary embolism, lung atelectasis, third day intra-abdominal hemorrhage, sepsis, fluid overload, or chest infections. So any of this can lead to such type of problem. So why pulmonary embolism is suspected? Pulmonary embolism. Why it is suspected? So patient is having heart rate is increased, tachycardia, tachypnea, and PaO2 is decreased. Patient is immobilized and hypercoagulability in malignancy. So this patient management may involve as a CCRISP CRISP protocol A, B, C, D, E. So how to start this management? About airway, what you have to look after is patent airway is there or not. Breathing is to be, oxygen has to be given by the non-rebreather mask, roughly about 15 liters. If not improving, you need anesthetics and do intubation. Then I will assess the circulation. How circulation? It should be white or middle, Cannula, white bore cannula has to be put. One has to start IV fluids, Hartmann solution, manage, check for BP, urine output, capillary refill. Inform seniors. Then investigations here to order is ABG, as blood gas analysis, ECG, chest X-ray, and if you are suspecting pulmonary embolism, it is CTPA is the gold standard. Then what if patient is stable? How is the management? Patient is stable or patient is unstable. So what we do, if patient is stable, start low molecular weight heparin. If unstable, moderately unstable, catheter directed surgical embolectomy. If it is massive pulmonary embolism or saddle embolism like this, surgical embolectomy, and parental if the heart is splitting surgical embolism, catheter directed lysis. So ABG report gives, if the ABG report has got pH 7.49, PO is 8, PCO2 is 3.8. PCO2 PCO2 is decrease, PO2 is also decrease, pH is alkalosis. So this is respiratory alkalosis. What do you think the patient is respiratory? Because of hyperventilation. Patient is taking a lot of breathing, so CO2 washout is there. So on ECG, what you will see in pulmonary embolism. So there is right ventricular hypertrophy or right ventricular failure. The signs, it should be sinus rhythm. So gold standard is CTPA. Then example we show CTPA, and what you will see, pulmonary vessels. You have to identify pulmonary vessel. If it is clogged, then so pathogenesis. Now if you see pulmonary vessels resisting pulmonary embolism. Now clots. What about clot formation? What is pathogenesis? How clots are formed? So there can be different stations like bleeding pseudoaneurysm. What happens in these? There is epithelial injury, blood stasis, platelet elevation, viscosity. So that is what was tried. So coming to another stem, which shows 65-year male having diabetes mellitus on oral medications and perianal abscess. Now what you are going to do, incision and drainage. So this is about the diabetes case. So what are the different types of DM? It can be 1 or 2. One is insulin dependent, this is non-insulin dependent. So here is deficiency of insulin. Insulin cannot be secreted, damaged, so here you have to give injections of the insulin. And here there is peripheral cells have got resistance in type 2. So even if you give insulin, insulin can be normal, but it doesn't act. So here he needs oral antihypoglycemic drugs. So what is the function of insulin? What does it causes? So insulin helps to decrease blood glucose level by various carbohydrate, protein and fat. It helps in all this. So what do we do here? So glucose, basically glucose uptake into the cells, intracellular. Then glycogenesis. So glucose is converted to glycogen and stored in the liver. So that reduces hepatic generation of glucose 6-phosphate from glucose. So glucose is converted into glycogen and glucose 6-phosphate. It reduces blood glucose BSL level. So protein, again uptake is increased because of insulin. Protein synthesis. It is one of the growth hormone. Then fat, what does it causes? Because protein. Then fat, what do it do? Stimulates the lipids. So lipid uptake. Again, lipid uptake, oxidation, oxidation, and also fat deposition, lipogenesis. So what are the different hormones that affect blood glucose level? So blood glucose level is affected by different groups of hormone. The common is insulin that decreases the blood glucose by cellular uptake. The glucagon, along with the insulin, glucagon that increases blood glucose level. Catecholamines and somatotrophin, also growth hormone. So what are the precautions? What precautions should be given for patient of diabetes mellitus who has to undergo surgery to prevent hypoglycemia? Intraoperative, there should be not be hypoglycemia. What precaution we will do? It has to be pre-op, proper routine overnight admission, not necessary. Starvation should not be no more than one meal. So it should not be only one meal miss. APG and potassium levels are important. So during and after surgery, what you will do during and after surgery? Patient with diabetes must be in the top of the list. There has to be in the top. And if diabetes controlled by oral medication, if patient is on oral medication, just omit that drug. If it is on the short acting insulin, so what you will do, short acting insulin, variable, it has to be variable scale. So patient is expected to miss one more limb. If missing more than one, not oral medication, not controlled, then you have to go. Analgesic antiemetics are to be given. Analgesics, antiemetics, 0.4% sodium chloride, 5% glucose, and KCl, potassium chloride. These are to be given. So every 4 hourly blood glucose, and target blood glucose should be 6 to 10 target. It should not go in this. So what can be the post-operative complications? So complications, again the common hyper, increase or decrease blood glucose level, diabetic ketoacidosis, dehydration. So late complications are delayed wound healing, sepsis, wound infection. What are the lab? What should be the lab? Blood investigation. What you will do? So lab investigation is blood glucose level, serum potassium level, ABG, HbA1c, to know whether it is long-term control. Long-term control is there or not. So for ketones, post-operative will be involved, the diabetic nurse, GP of the family.